very important topic integrated with surgery. Such an important topic. Okay, which is neonatal cholestasis. Neonatal cholestasis. Cholestasis means the direct jaundice level is going to be elevated. I told you whenever the direct is elevated, it is pathological. Okay, pathological. So the most common cause of neonatal cholestasis is extrahepatic biliary atresia is the most common cause. Features will be jaundice, high colored urine and clay colored stools. Just like any obstructive jaundice, they will have the features. Conjugated fraction will be elevated. Ultrasound is the initial investigation you will do. Okay, so initial investigation which you will do is called as ultrasound, which will show the triangular cord sign and poor contractile small gallbladder or absent gallbladder. Okay, fine. Next, you can do HIDA scan. So HIDA scan is not diagnostic. It can be done, but based on that, it is not diagnostic investigation. Okay, which will show the excretion of the bile. Yes. Next question. So what is the confirmative test or which test you can use to differentiate between other causes? It is liver biopsy. See, I am telling the exact words because exact words will be asked. Okay, liver biopsy is used to differentiate between other causes of neonatal cholestasis. Differentiate between other causes of cholestasis. And in the liver biopsy, you will see fibrosis and proliferation. Okay, fibrosis you can see. Fine. What about investigation of choice? Even after liver biopsy, you want to confirm, then you will do peroperative cholangiogram. Peroperative cholangiogram. You can write it here also. Okay, fine. See guys, exact word please remember. If the question is, what is the initial investigation you will do? Then it is ultrasound. You will do ultrasound to know what is the problem. If the question is, which investigation is used to differentiate between extrahepatic biliary atresia and other causes of neonatal cholestasis, then your answer is going to be liver biopsy. What is that confirmative? It's not more of investigation of choice. You can make it as confirmative. The confirmative one is going to be peroperative cholangiogram. Fine. These are the three exact words I want you to remember. Fine. Yes. Fine. Treatment is Kasai's procedure. Kasai's procedure has to be done within the first 60 days. Within 60 days of birth, it has to be done. If it is not done within 60 days of birth, and the only thing that is left over is liver transplantation, that is why extrahepatic biliary atresia is the most common cause of liver transplantation in children. Fine. Clear? Every line is important here. So EHBA, please remember conjugated fraction will be increased. USG initial test. HIDA scan is not diagnostic. Liver biopsy is used to differentiate other causes. And confirmative is peroperative cholangiogram. Fine? Yes? Okay. Kasai procedure you will do in the first 60 days. It's a portoenterostomy. 2 MCQs, 1-liners. I have given you a scenario. You have to tell me what is the disease. Cholestasis, butterfly vertebra, triangular facies, pulmonary stenosis. What is this? What syndrome is this? Very good. Alagili syndrome. This is Alagili syndrome. Okay? Fine. Cerebrohepatorenal syndrome. What syndrome is this? Cerebrohepatorenal syndrome. Zellweger syndrome. Yes, Zellweger syndrome is cerebrohepatorenal syndrome. Zellweger syndrome is a peroxisomal defect. Okay, it is a peroxisomal defect. Clear? So, other 2 causes of neonatal cholestasis, Alagili syndrome. Please remember, pulmonary stenosis is a feature. Zellweger means brain is affected, your liver is affected, kidney is affected. Cerebrohepatorenal peroxisomal defect. Clear? Okay, so this is about neonatal cholestasis, triangular cord sign seen in your ultrasound. Fine. Important topic. 1-liner. Yes. Newborn is over and we are going inside development. Few important points in development we will see. Yes, what is this baby doing? What milestone is this baby doing? And what is the age of this baby? Yes, is it called as tripod position, sitting with support? The baby is sitting with support. Yes, tripod position, sitting with support. Fine. Which age? What is the age of this baby? 6 months. Yes, yes, yes. Sits with support at 6 months of age. We are going to see 6 months milestone. So 6 months the baby sits with support in gross motor. Fine motor, baby has unidextrous reach and it can transfer object. Okay, transfer object. Monosyllables, the baby speaks monosyllables, ba, ma and all. Stranger anxiety. All these comes around 6 months of age. Okay. So other gross motor milestones, neck control is the first one achieved in gross motor around 3 months. Baby rolls over at 5 months. Sits without support 8 months. Sits with support 6 months we have seen. So next is sitting without support. Standing with support 9 months. Standing without support what? 1 year. Walks by 15 months and the baby can run by 18 months of age. Okay, 18 months of age. Tricycle. When will a baby ride a tricycle? What age? Yes, yes. Three. Tricycle. Yes. When will a baby hop? And when will a baby skip? Hops by 4 years. I've told you, hops is a 4-letter word. 4 years. Skips by 5 years. Skips. 5-letter word. So skips by 5 years. Able to understand? So tricycle is 3 years. Hops is 4 years. And skips is 5 years. Okay, fine. So these are important gross motor milestones. In the glossary also, we have the important milestones, which we will do in glossary section. Fine? Yes. Next. Fine motor milestone. What is seen in the image? What is this called as? Holding something with the thumb and index finger. What is that called as? Mature pincer grasp. Very good. This is a mature pincer grasp. Okay. So immature pincer means the baby will hold with the whole of the fingers. This is called as immature pincer. Immature pincer comes around 9 months. Mature pincer comes around 12 months. Okay. After which the baby will start writing. So scribbling by 18 months. Vertical stroke 2 years. Circle 3 years. Cross 4 years. Rectangle 4.5 years. Triangle 5 years. So how do you remember? It is like a scarecrow being suspended. Okay. So 2 years, 3 years, 4 years, 4.5 years and 5 years. Triangle is 5 years. Okay. So these are some of the fine motor milestones. One more important thing I want you to ask. Handedness. At what age it is established? Question. INA question. Handedness is seen at what age? 3 years. Very good. 3 years. Second question. Early handedness, where will you see? Early handedness is a feature of what CP, guys? Hemiplegic CP. Okay, please remember hemiplegic CP. Early handedness is a feature of hemiplegic CP. Okay, so this is about the fine motor milestones. So gross motor, fine motor, important milestones we have done. So rest of the detailed development is seen in the glossary. We can read it from there. Fine, yeah. So continuing with VSV 55. Important topic. You cannot see a paper without this topic being asked, without this question being asked. Such an important topic. So many questions can be asked from this Kawasaki disease. Kawasaki disease. So look at the images. What do you see in the images? Strawberry tongue, conjunctival congestion, rashes, edema and erythema of the hand and foot. These are all the features of Kawasaki disease. So it is a mucocutaneous lymph node syndrome. Other name was mucocutaneous lymph node syndrome. The criteria is crash burns. Yeah. So what is it? It is a medium vessel vasculitis. It is a vasculitis, medium vessel vasculitis, not an infection. So crash burns, what is this crash burns? Burns is fever, high grade fever for 5 days must be there, plus any 4 out of the 5 which I am going to say. Okay. So any 4 out of this should be there. R, C, conjunctivitis. How is the conjunctivitis? This was the INS set question asked. How is it? Non-purulent. Okay, non-purulent and bilateral. It's not purulent, non-purulent, bilateral. Rashes are polymorphous rashes. Are A is for adenopathy. Yes. A is for adenopathy. Cervical adenopathy, unilateral, at least 1.5 centimeter in size. S is for strawberry tongue. H is for hand and foot edema and erythema, followed by, in the 2nd to 3rd week, you will have periungual desquamation of skin. This is the important classical feature of Kawasaki disease. One-liners and questions which will be asked from Kawasaki. It is the most common cause of acquired heart disease. Previously, it was rheumatic heart disease. Now, Kawasaki. Kawasaki is the answer. Especially in Asia. Especially in Asia. The most common cause of acquired heart disease in Asia is Kawasaki. Okay, the most common vasculitis in children in Asia is also Kawasaki. Okay, most common vasculitis in children in Asia is also Kawasaki. Most common cause of heart disease in Asia is also Kawasaki. What is the most common cause of death? MCQ. Very good. Coronary artery aneurysm. Coronary aneurysm. Very good. Coronary aneurysm. Drug of choice. Drug of choice. Another INSET question. IVIG. Very good. Intravenous immunoglobulin is the drug of choice here. So if treatment is asked, you can give IVIG and aspirin also. Okay, IVIG and aspirin. But here, if the question is drug of choice, both will be there in the option. Please choose IVIG. Don't choose aspirin. Drug of choice means please choose IVIG. If the treatment is asked means you can choose both. Able to understand? Fine. Yes. So this is about Kawasaki. All these are important things in Kawasaki. Okay, fine. Moving on to the next VSB, another pediatric rheumatological condition. It's a favorite image-based question of INSET examiners. Okay, so what do you see here? What is the first image? You see some rashes in the interphalangeal places. What is that? Yes, that is called as Gottren papule. Very good. That is called as Gottren papule. Good. Okay, this is Gottren papule. Second image where it shows like someone is wearing a shawl, it is called as shawl sign. Okay, it is called as shawl sign. Third image where you see rashes around the eyes and in the malar aspect, what is that called as? Heliotrope rashes. Okay, so these three are features of juvenile dermatomyositis. So juvenile seen in children, skin as well as myositis, muscle fainting. So very important, it is a symmetrical proximal muscle weakness. Symmetrical proximal muscle weakness, heliotrope rashes, Gottren papule, shawl sign, image based. CPK levels will be elevated. Biopsy will show a finding called as perifascicular atrophy. Treatment is steroids and methotrexate. Okay, that's all. That is about JDM. Images are possible. Image based questions are possible. Yeah. Moving on to the next VSV, VSV 57. So what is VSV 57? VSV 57, you see palpable purpura over the lower limbs. When that typical word is given, palpable purpura, your diagnosis is Henoch-Schönlein purpura. Your diagnosis is Henoch-Schönlein purpura. Okay, fine. Yeah. So Henoch-Schönlein purpura, palpable purpura you see in the lower limb. It is the most common vasculitis in children in world. Asia, I told you, Kawasaki. In the world, if the question is asked, means it is HSP, Henoch-Schönlein purpura, also known as IgA vasculitis. So features, tetrad of features will be there. Palpable purpura, usually in the dependent areas like legs, buttocks and all. Arthralgia, abdominal pain and renal features. Fine. Platelet count is normal. Important guys, please don't think it's a purpura, it's vasculitis. Because of that only there is going to be problem. It is not because of thrombocytopenia. Platelet normal. Biopsy will show leukocytoclastic vasculitis or IgA deposition. Treatment is supportive usually. If they have severe GI features like severe abdominal pain, if they have severe GI features like severe abdominal pain, you will give steroids. It is a recent INICET question. What is the indication of steroids in HSP? When severe GI features are seen, steroids are indicated in HSP. Clear? Yes. So this is about the third vasculitis. So rheumatology, we have seen HSP, we have seen JDM, and we have seen Kawasaki. Very, very important, all these three. Fine? Yeah. Let's continue with the other topics. Now we are entering into systemic pediatrics. Very, very important topics are ahead of this session. Yes. The first is umbilicus. With umbilicus, we are going to see so many important topics and important questions will be asked. So look at the umbilicus. There are two arteries and one vein. What is that one vein? It's a left vein. It's a left vein. Okay, left is left. Right will obliterate. What is that remnant called as? Umbilical vein remnant is called as? Umbilical vein remnant is called as? Yes, ligamentum teres is given here. Ligamentum teres is the umbilical vein remnant. Okay. So what about the remnants? The remnants are very, very important. Okay. So what is the umbilical artery remnant called as? Remnants we are going to see. Umbilical artery remnant. Artery. Umbilical artery. Medial umbilical ligament. Medial umbilical ligament. Okay. That is umbilical artery. Okay. What about urachus? Urachus is only median umbilical ligament. Median umbilical ligament. Urachus is median umbilical ligament. So please remember the remnants. Okay. So normal length of umbilical cord at birth. What is it? 55 centimeter at birth. What is delayed cord clamping? Ionized question. What is delayed cord clamping? After 30 to 60 seconds after birth, you will clamp the cord, that is called as delayed cord clamping. So it is used to prevent anemia in term babies. What about preterm babies? Can we do delayed cord clamping? Can we do delayed cord clamping? Preterm babies, yes, we can do. Okay, in preterm babies, it is used to prevent IVH. In preterm, this was the previous exam question, guys. In term babies, it will prevent anemia. In preterm babies, it will prevent IVH and other complication. But where you will not do delayed cord clamping is not done where? Not done in babies needing resuscitation. Okay, not done in babies in need of resuscitation. That time you will not practice delayed cord clamping. Okay, fine. Yes. Delayed fall of umbilical cord. Which condition you will see? MCQ. Delayed fall of umbilical cord, where you will see? Yes, leukocyte adhesion defects. Very good, lad. Leukocyte adhesion defects. Leukocyte adhesion defect. Yes. Next question. Recent ionized question. Umbilical stump bleeding. A newborn present with umbilical stump bleeding. What is that defect? Which deficiency? Very classical. Factor 13 deficiency. Factor 13 deficiency. Okay. Fine. What is that other problem where newborns can present with bleeding manifestations? What is that called as? Newborns presenting with yes, vitamin K deficiency. What is that called as? HDN. What is HDN? Hemorrhagic disease of newborn. So hemorrhagic disease of newborn is because of vitamin K deficiency. Okay, that is why at birth you will give vitamin K to all babies. So it is because of vitamin K deficiency. Okay. So what are the vitamin K dependent clotting factors? What are the vitamin K dependent clotting factors? Another MCQ. Yes. 2, 7, 9 and 10. 2, 7, 9 and 10. Okay. So 2, 7, 9 and 10 are vitamin K dependent clotting factors. Able to understand? So this is with regards to umbilicus. With umbilicus we have discussed so many topics here. Remnants. Then delayed cord clamping. Where will you do? Where you will not do? This is based on the guidelines in your reference book. Okay. Delayed fall of umbilical cord, where you will see umbilical stump bleeding, where you will see, and what is HDN. Clear? Yes. Moving on to the next VSV. So the next VSV is fetal circulation. So fetal circulation extensively we have discussed already. Now what we are going to the key points. What all can be asked in the question that we are going to see. Okay. So fetal circulation starts from placenta. Tell me, oxygenated blood is carried by whom? Umbilical vein. So oxygenated blood is carried by umbilical vein. Deoxygenated blood is carried by whom? Umbilical artery. Yes. So they have three bypass mechanisms. What are they? Ductus venosus, ductus arteriosus, and foramen ovale. Okay. So ductus venosus, where it is present? Between two veins. A duct between two veins. What are the two veins? Umbilical vein and IVC. Ductus arteriosus is an artery between. Yes. It's a duct between two arteries. What are they? Pulmonary artery and aorta. And fetal circulation, very important key point you have to remember is pulmonary pressure is high in fetal circulation. Whereas in adult circulation after birth, your systemic pressure will be high. Okay. Now, among all the vessels, which vessel has highest saturation? Who is coming from the placenta? Who is going to have highest saturation is umbilical vein. Umbilical vein has the highest saturation. See, each and everything here is an MCQ. Okay. So closure, the order of closure is ductus venosus followed by ductus arteriosus followed by foramen ovale. So the mnemonic is V A O. Ductus venosus closes first, followed by ductus arteriosus, followed by foramen ovale. Ductus venosus usually closes by day 7. Ductus arteriosus closes by day 21. Foramen ovale takes 2 months. All this means the anatomical closure. Okay, functional closure happens at birth. Anatomical closure takes certain time. So VAO is the mnemonic, day 7, day 21 and 2 months. Okay, fine? Yes. So next important question, ionicate question, ductus arteriosus is closed by dash. What is that factor which closes ductus arteriosus? Very good. Increased oxygen tension and decreased prostaglandin. Increased oxygen tension and decreased prostaglandin. So these are the factors which results in closure of ductus arteriosus. Okay, closure of ductus arteriosus. Fine? Yeah. So that is about fetal circulation and important MCQs from fetal circulation. So now we are going inside the cardiology. Yes, few important topics we are going to see. First one is VSD, ventricular septal defect, VSV60, which is the most common congenital heart disease overall. Okay. Acyanotic, yes, it is a left to right shunt. Increased pulmonary blood flow is seen. Most common type is membranous. Okay, most common type is membranous. Which is the most common type which undergoes spontaneous closure, guys? What is the answer? Spontaneous closure? Muscular, good. Muscular undergoes spontaneous closure. Yes, muscular undergoes spontaneous closure. Characterized by pansystolic murmur in the left lower sternal border. Chest X-ray, you will see cardiomegaly. Complications, you can have infective endocarditis, failure to thrive. Yes, failure to thrive. Congestive cardiac failure, respiratory infections. All these are complications of VSD. It's the most common congenital lesion complicated by infective endocarditis. Okay. Surgery, if you want to take, you will do patch closure. Medical treatment, you will treat anemia and CCF. Complication of surgery is complete heart block, residual VSD and tricuspid regurgitation. These are the complications you can see after the closure. Okay. So MCQs here are these two, the most common type and most common closure can be asked. Then feature they can be asked. So pansystolic murmur in the left lower sternal border is a feature of VSD, and complication of VSD, failure to thrive is also a complication of VSD. Fine. That is about VSV number 60, VSD. Yeah. Moving on to the next VSV. So the next VSV is PDA. What is PDA? Patent ductus arteriosus. Just now we saw ductus arteriosus is a duct between two arteries. What are the two arteries? Pulmonary artery and aorta. After birth, they have to close. If it is not closed, it will result in a condition called as PDA, patent ductus arteriosus. So it is also a acyanotic heart disease because it is also left to right. Here also blood flow is increased. Pulmonary blood flow is increased. Risk factor. What are the risk factors? Prematurity and high altitude. Okay, preterm babies and high altitude. So here you have a continuous murmur called as a machinery murmur, continuous murmur. Complications, again you can have CCF, infective endocarditis or complications of PDA. Medical treatment, you can give brufen, indomethacin. They are prostaglandin inhibitors, so they can help in closure of PDA. Closure of PDA. Surgery is ligation or occlusive devices. Very important, if PDA has increased pulmonary tension, which is called as Eisenmenger syndrome. What is that feature? If PDA has Eisenmenger syndrome, they will result in differential cyanosis. Upper limb will be normal, the lower limb alone will have cyanosis. That is called as differential cyanosis. Okay, so this is about PDA. So risk factors are preterm and high altitude. Okay, fine. One more NEET-PG question. Okay, indomethacin in pregnancy, what will happen? You told there is for closure of PDA, we are going to give indomethacin. Suppose mother is taking indomethacin in pregnancy, what will happen? Very good. Premature closure of ductus. Premature closure of ductus. Okay, this is a NEET-PG question. NEET-PG question. So this is about patent ductus arteriosus. Patent ductus arteriosus. Yes. Few X-rays, classical X-rays. Quickly we can complete all of this. What is this appearance? Yes, snowman appearance or figure of 8 appearance. What is this? TAPVC. So what is TAPVC? Total anomalous pulmonary venous connection. TAPVC is total anomalous pulmonary venous connection. Total anomalous pulmonary venous connection. It is a cyanotic heart disease, guys. It is a cyanotic heart disease. It is characterized by increased pulmonary blood flow. So two important one-liners that can be asked. Total mixing of blood is seen where? TAPVC. Same saturation in all chambers is seen where? TAPVC. Okay, fine. So chest X-ray will show this characteristic figure of 8 or snowman appearance. But to be very specific, it is a feature of supracardiac TAPVC. It is a feature of supracardiac TAPVC. What about infracardiac or obstructive TAPVC? Ground glass appearance. So it will mimic what? What is the closest mimicker of TAPVC? Very good. Respiratory distress syndrome. Okay. It mimics respiratory distress syndrome. Very good. Clear? Fine. So this is TAPVC. You have snowman appearance or figure of 8 appearance. Fine? Yes. So moving on to the next VSB. So next VSB, what is this? Huge heart, cardiomegaly. Huge heart, box-shaped heart, cardiomegaly. Where will you see? Epstein anomaly. Very good. Epstein anomaly. Cyanotic heart disease. Again, it is characterized by reduced pulmonary blood flow. Risk factor is maternal lithium intake. Okay. Feature is there is downward displacement of the tricuspid valve. Tricuspid valve is displaced down. Because of that, a part of the ventricle becomes part of the atrium. So it is called as atrialization of right ventricle. Chest X-ray will show box-shaped heart. Okay, and then you can see WPW syndrome also. Wolff-Parkinson-White syndrome can also be associated with this condition. Okay, so this is Epstein anomaly, box-shaped heart with huge cardiomegaly. Fine, yes. So now, a quick reminder of what are the lesions which have increased pulmonary blood flow and what are the lesions which have decreased pulmonary blood flow. Okay, so increased pulmonary blood flow, all your defects like ASD, VSD, PDA, all three of them are going to have increased blood flow. Other than this, TAPVC is going to have increased pulmonary blood flow and TGA, just now we saw, no, increased pulmonary blood flow. These are going to have increased pulmonary blood flow. Pulmonary blood flow will be decreased in Epstein, tricuspid atresia. What is that one more important heart disease, cyanotic heart disease, where pulmonary blood flow is of importance? What is that? TOF, very good. TOF, you will have decreased pulmonary blood flow. Able to understand? Okay, fine. Yes. Moving on to VSB 64. VSB 64, what do you see here? Yes, you see this 3 sign and inferior notching of ribs. So 3 sign in X-ray with inferior notching of ribs is a feature of coarctation of aorta. Coarctation of aorta. So it's an acyanotic disease because there is no mixing of blood at all. Feeble lower limb pulses, radiofemoral delay, hypertension and intermittent claudication. This is the exact important features. Okay. And on examination, you will see a sign called as Sussman sign. Sussman sign. So you will have in the interscapular area, you will hear some murmurs. That is called as Sussman sign because of the collaterals. So severe aortic coarctation in neonates becomes a duct-dependent circulation. Yes, chest X-ray, 3 sign is seen, inferior notching of ribs. If you do a barium meal, you will see E sign or an inverted 3 sign. E sign or an inverted 3 sign. Okay, so these are the features. What syndrome is associated with coarctation of aorta? Which genetic syndrome is associated with coarctation? Turner syndrome. Good. Turner syndrome. Turner syndrome. Okay, is associated with coarctation of aorta. Fine. Yes. So with this, we are going to see what is duct-dependent systemic lesion, what is duct-dependent pulmonary lesion. Fine. So duct-dependent systemic and pulmonary lesions we are going to see. So what are the duct-dependent systemic lesions you know of? Which means without ductus arteriosus, these babies cannot survive. So what are the duct-dependent systemic lesions? Left side lesions. Very good. Hypoplastic left heart syndrome. Hypoplastic left heart syndrome. Left side. Then very good. Severe aortic stenosis called as critical aortic stenosis. Severe aortic stenosis and severe coarctation. These three are left side dependent on systemic circulation, duct dependent systemic circulation. They will present with features of shock. They will present with features of shock. Duct dependent pulmonary lesions means right side lesions which is dependent on ductus arteriosus. What are they? Severe Epstein anomaly. Severe Epstein anomaly. Then, yes, pulmonary atresia and severe pulmonary stenosis. Okay, they are dependent on duct for the circulation. So these patients will present as cyanosis. Okay, so duct dependent systemic will present as shock, duct dependent pulmonary will present as cyanosis. Treatment. If there is a duct dependent lesion, what will you do? That is the question. In any of this, if you diagnose it as a duct dependent lesion, what will you do? It is dependent on duct. So what you have to do? You have to keep the duct open. Very good. To keep the duct open, what will you use? To keep the duct open, what will you use? Very good. Prostaglandin E1 analog called as alprostadil. That's all, guys. So to keep the duct open, you will use prostaglandin analogs like alprostadil. To close the duct, you will use indomethacin or ibuprofen. Clear? So where to use, what to use is very, very, very important. This is coarctation of aorta. Okay, fine. Yes. So we are moving on to the next one. The next one is an important heart disease called as tetralogy of Fallot, TOF. So tetralogy of Fallot, it is the most common cyanotic heart disease. Okay, it is the most common cyanotic. Overall is VSD. In cyanotic, most common is TOF. Reduced pulmonary blood flow, we have already discussed. Components, there is going to be VSD, right ventricular outflow obstruction, right ventricular hypertrophy, and overriding of aorta. Overriding of aorta. Single S2, you will have only single S2 and ejection systolic murmur. Chest X-ray will show this characteristic boot-shaped heart, and pulmonary oligemia means blood flow is reduced. All pulmonary reduced blood flow is pulmonary oligemia. Complications, infective endocarditis, thrombosis, brain abscess can be there, but no CCF. Okay, so complication, you will not have CCF. No CCF. Treatment, definitive surgery. The name of the definitive surgery is, you will close the VSD and you will relieve the spasm. That is definitive surgery. But the name of the palliative surgery is BT shunt, modified Blalock. That is not definitive, it is palliative. So what will you do? You will keep a graft, Gore-Tex graft between pulmonary artery and subclavian artery. Okay, that is called as modified BT shunt. Okay, post-operative complications, you can have heart failures and arrhythmia. Heart failures and arrhythmia. So these are the important points with regards to TOF. Comes the question. Boot-shaped heart, TOF, everyone knows. But why it is due to? Why do you have boot-shaped heart in TOF? What is the reason for boot-shaped heart? Any idea? Very good. Right ventricular hypertrophy is the reason for boot-shaped heart. This is an ionicate question. Yes. What is pink Fallot? What is pink Fallot? No cyanosis. You have TOF, but there is no cyanosis. That is pink Fallot. What is pentology of Fallot? What is pentology of Fallot? Very good. TOF plus ASD is called as pentology of Fallot. Okay. And cyanotic spell treatment, key points alone we will see. When a child is having cyanotic spell or also known as TET spell, what you are going to do is oxygen, yes, morphine, and a characteristic position called as squatting position. Okay, so oxygen, squatting position, morphine, then you will give soda bicarb, phenylephrine, propranolol. Okay, so these are the drugs used in cyanotic spell treatment. So TET spell also known as oxygen, morphine, squatting position, soda bicarbonate, phenylephrine and propranolol. So these are the drugs we can use in cyanotic spell treatment. So this is about TOF. So TOF, very important is the components of TOF. X-ray, very classical question. So you have to know why it is due to complications, treatment and the cyanotic spell treatment of TOF. Fine? Yes? Yes. So next VSV, TOF is over. One more heart disease where you can expect questions from the X-ray is this one. Egg-on side appearance or egg-on string appearance, which is nothing but TGA, transposition of great arteries. Great arteries are transposed. It's a cyanotic heart disease. Increased pulmonary blood flow, we have discussed. Very important key point, parallel circulation. Okay, this is called as parallel circulation. It's also seen in infant of diabetic mother. Chest x-ray will show egg-on side or egg-on string appearance. Treatment is Jettine's arterial switch procedure. Okay, they will do an arterial switch procedure. So that is about transposition of great artery. Okay, okay guys. So now the time is 11:55. So we'll take a 5-minute break before we go on to the acquired heart disease. So far we have completed congenital heart disease from cardiology chapter of pediatrics. We are going yet to move on with the acquired heart disease. So we'll have a short 5-minute break and 12 o'clock we'll continue with the rest of the CVS.